And hello, good evening, community members. My name is Antoine Craigwell, and I'm President and CEO of DBGM, the organization that's bringing this evening a discussion on the future in HIV care, a discussion on HIV, mental health, and the Black gay man. Um, Given all that is going on in our world today, especially in our country, we need to stop and consider how HIV is impacting Black gay men. But more so, with the COVID virus, there are all sorts of people who have questions and concerns that we've been waiting almost 40 years for an HIV vaccine, but now in less than 10 months, we got a COVID virus vaccine. And there are a number of reasons why and all sorts of stuff that's going on about that, but it still raises a lot of issues. This evening as well, we want to talk about what does HIV look like in the future for Black gay men. So we've got a couple of people online with us this evening. We've got Kenyon Farrow from the Treatment Action Group. We've got Ty Martin from SAGE, who will be talking particularly about all the Black gay men who've been living with HIV. What does the future look like for them? We've got Jahlove Serrano, who's coming to us from the Caribbean Equality Project, which is based in Queens, New York. But more importantly, Jahlove is going to be talking to us about shame, stigma, and what does that look like again for Black gay men going forward? How do we change those narratives and break down the shame and stigma? And then we've got a special guest, somebody who's been trying for the longest while to be part of all of our activities. A young man by the name, and I'm going to call him Kachi for the time being, because his name is one of these Nigerian names that is so long. So I'll call him Kachi for the time being. And Kachi is now in the United States from Nigeria, and he will talk to us about HIV in Nigeria and in Western Africa. What does that look like? And what does the future look like for Black gay men in those communities? And then following Kachi or Tai, we will have Tim M. West, who will be joining us a little later this evening to do some stand-up, to do some poetry with us, some spoken word with us, and to give us some perspective about how he sees HIV going into the future for the rest of this year and for the next several years. And so with that in mind, I'd like to ask you all now to let's take a moment in silence as we remember those members of our communities who've died from HIV/AIDS, or now the combination of HIV/AIDS and COVID virus. Thank you very much. So for those who are joining us, we ask you to keep your microphones muted. We ask you not to take photos of the screen. Please be respectful, even if you disagree with someone. And we will use a chat box. I'm sure a lot of you who are doing Zoom are familiar with chat boxes to put your questions in. We will have a question and answer period at the end of all of our presentations. And we will share the slides and recordings with anyone who requests them. Our first speaker is Kenyon Farrow with the Treatment Action Group. Kenyon is the US and Global Health Policy Director for Treatment Action Group, an independent AIDS research and policy think tank fighting for better treatment, a vaccine, and a cure for AIDS, TB, tuberculosis, and hepatitis C or Hep C. In addition, at TAG, Kenyon is working to organize campaigns in cities and states to drive the end of the HIV epidemic. He recently published a qualitative research project exploring the role of community mobilization in the US HIV response in 9 cities. He is also the former executive director of Queers for Economic Justice and has a long track record of community organizing work on criminalization, mass imprisonment, homelessness, and HIV issues. Community members, I'd like us to welcome Kenyon.
Great, thank you so much. First and foremost, let me just say I'm no longer the policy director at Treatment Action Group. I'm still very friendly with them and done some consulting with them since my tenure. But that is certainly a place I've worked. I'll talk a little bit about I think the sort of healthcare infrastructure as it pertains to HIV and where I see things going and where I see the potential for, I think, some work, some activism and advocacy, I think that we're going to have to do. So first and foremost, when we now, I mean, in the last roughly 10 years, when we think about, how well we're doing as a country and certainly how well we're doing among Black gay men in terms of the HIV epidemic, we use the HIV care continuum as a marker of, where we are. And if we look at that kind of most recently published data, which the CDC, to my knowledge, has not updated since 2016 when I was looking for this earlier today, in this country, the richest country in the world, right, we still are only around, 55%, I'll be generous and say 60%, but the most recently published data I could find was somewhere around 55% viral suppression in this country. And I think that tells us a lot about how much work we have to do in terms of reaching more folks and being able to actually provide the kind of care that people need, right? So it's one thing to say that, which I often hear from people when we talk about, getting HIV care in this country. People have, Ryan White, right? If nothing else. And if you don't know, Ryan White Care, Act is the, federal program that provides, medical services and some wraparound services for people living with HIV, and is often the, we call the payer of last resort. So if you don't have private insurance, you don't have Medicaid, et cetera, then you are able to get, Ryan White to take care of your HIV care or to kick in resources to pay any what would be potential out-of-pocket expenses for, HIV medications. And one of the things that we understand, about that system, while we're definitely lucky to have it, but there's still a lot of problems with that people have in terms of, accessing care. So I was for 3 years until this past summer, the senior editor of thebody.com, if you're aware of The Body, the HIV news and information resource website. And while I was at The Body, we published a couple of years ago 2 stories. I'll drop it in the chat box for folks who are interested to take a look at. But 2 stories by young gay men, one Black gay man, one white gay man, but both who moved to Atlanta, Georgia. From one moved, Mikey Lamb's white gay man moved from Florida to Atlanta, and Mason, who moved from Boston, Massachusetts to Atlanta, and both of whom have work histories doing both HIV prevention and also working as linkage to care specialists, and moved to Atlanta, Georgia. And despite their expertise in knowing how to navigate that system, could not navigate it, and both of whom fell out of care and were without antiretroviral medication for weeks, and in one of their cases for months, until we published those stories, right? And so when we think about that and the fact that, 2, young men who were at the time both under 30, but who knew how to navigate the system, and in fact had been hired at other community-based organizations to help people navigate the HIV care system, could not navigate it for themselves in Atlanta enough to get themselves in care. And so the question has to then be asked, what happens to people who, are not community leaders, who are not activists, who don't know the system, who get diagnosed and are scared and are told, to call this number, call that number. They're given the runaround. They don't have this piece of paper because they don't have insurance, then they don't, can't do X, Y, Z, all the sort of things that happen to people. A lot of people just frankly give up. And I think all of us are probably aware, some of which out of stigma, but some of which I think out of some of these ways in which actually accessing care, if you're living with HIV in this country, is still in some places around the country, unless you're in a, kind of either a big city or a place with a large, kind of medical research center. You're dealing often with doctors and case managers who may not, frankly, know a lot about HIV or know how to navigate the system for you. And so I think that we often, talk about kind of stigma as a killer, and still people dying young from HIV due to stigma. And I think that we often don't look enough at some of these systematic issues with how difficult it is to either get care and stay in care because of challenges. And this even happens in New York City. My ex-partner, who is living with HIV, Black gay man living in New York City, still has problems with, paperwork not being filled on time by caseworkers or et cetera, showing up to pick up his ARVs at the pharmacy and they don't have a renewal for his, health care. And so, he doesn't have $3,000 to pay for medication, et cetera. So we live in a country where, despite on paper, I think having some of these, benefits in terms of being able to access care, but I think that we still have a lot of a way to go in terms of making it as easy as possible for people to, access care, and be able to sort of stay in care that would go greatly towards, some of the work that, many of us have been a part of in terms of, ending the epidemic federally. Last thing I'll say in my opening remarks before turning it over is we do, in the space of the science, have, some additional tools coming down, the pipeline, right? So we have at least one, probably soon to be approved by the FDA, long-acting injectable medication for people living with HIV. So it would involve taking one shot. Well, actually, it's not in the arm. It's actually a shot in the glutes, in the behind. But that shot, if I'm not mistaken, it will be administered every month. So for people for whom pills are a challenge or a way to sort of address some of the adherence issues, the injectable might be a good option for folks. We still have some work to do in terms of building up the infrastructure for that, right? Because a shot is probably going to involve going back, that's going to be more clinical visits. And we have to have nurses and physicians who can administer those shots in their day, as opposed to just going to the pharmacy and picking up a set of pills. So I think, but, it could be an option for folks who, for whom pill adherence is difficult, or people who don't want to, kind of have pills in their house for various reasons, and for, Black gay men who may be in college and, not want to have those in their dorm rooms, or, or even in homeless shelters or whatever, just because of the kinds of stigma that exists. The injectable may be, a beneficial, option. So, last thing I would say, too, is just, I think, there's obviously in the current or the upcoming presidential administration, the Biden administration, there's going to be a lot of conversations about the future of the Affordable Care Act, whether and a push by a lot of activists for Medicare for all or a single payer system. But there will be discussions, obviously, about whether we need a public option or something that isn't all the way to Medicare for all, but some other things. And I think we have to be involved in those conversations as Black gay men and looking at the future of HIV care and what any of these proposals mean, hopefully to expanding access to more people, as opposed to what we currently have, I think, in terms of a real patchwork of payers and systems that are really difficult for, a lot of people who are, not well versed in this system to navigate. I'm personally not living with HIV. I feel I'm kind of an ally to the community. But I've been on PrEP now for going on 6 years this April. And when I started PrEP, even after having worked in HIV for so long, it gave me a very new perspective on what it means to have to engage the healthcare system on a regular basis, right? Before PrEP, I was, I get my annual physical every year. I go to the doctor if I needed something, get, an HIV test, get STI screenings, et cetera. But when you have to then deal with, prior authorization with, a medication and dealing with your insurance company every month, to having to keep up visits and appointments and that kind of thing, it gave me a different appreciation for what people who live with chronic illness, in this case HIV, have to deal with on a daily basis, right? And and so I am very much interested in kind of what we're doing to help make those systems easier for people to be able to get the kind of access to care that we claim that people have, but we know can be very difficult in a lot of circumstances. So thank you very much.
Thank you very much, Kenyon. I am listening to you talk, and a whole host of questions are coming up in my mind. And even though I'm the moderator, I am trying to hold myself back from like, but Kenyon, what about this and what about that? And I'm like trying to hold myself back. So somebody help me over here. Thank you very much, though. And I think there's a lot of questions that I may have, but I think also others may have. And I see a couple of questions in the chat already, which we will try to look at towards the end of the presentation. Hang on. Our next presenter is Jahlove Serrano, and Jahlove Serrano comes to us courtesy of the Caribbean Equality Project. So community members, Jahlove, use the pronoun he, him, his, is a healthcare youth educator, youth advocate, HIV/AIDS activist, androgynous model, runway coach, drag queen, background dancer, and choreographer to the stars. He's also a Bronx native of Belizean and Guatemalan descent. Jahlove's peer leadership began shortly before turning 16 when he contracted HIV and made a decision to be very public with his HIV status. He did this in order to combat the ignorance and stigma surrounding HIV/AIDS within the Black and LGBTQ+ communities and in the Caribbean diaspora. Grounded in social and racial justice, Jahlove has been working in the field of HIV/AIDS prevention, outreach, and research on a global, national, and city level to address the needs of HIV-positive youth and with youth in general, regardless of their status, to address homelessness, access to education, and culturally competent mental health and HIV treatment. Community members, I'd like us to welcome Jahlove Serrano. Jahlove.
Hello, hello. Happy New Year, everybody. Thank you for having me. I'm so excited to be here today. Bit nervous, but I'm gonna work through my nerves. So today, we talk about my history on addressing the shame and the stigma and how I was able to navigate it. So being raised in a heterosexual Catholic Latino, Afro-Latino household, sex wasn't a topic or discussed at home. And which led me to finding about my self-identity and sex in the streets, what led me to contracting HIV, my first sexual encounter, 15 going to 16. And I didn't get myself tested until I was about 18. I didn't know New York state laws that as long as I was 13 years of age and above and could give consent, that I was able to get tested. After finding out my diagnoses, and understanding that I'm Black, I'm gay, I'm HIV positive, living in America, the shame had really sit in with me that I wasn't able to navigate my healthcare. It was difficult for me to even go to my clinic visits because I didn't want anybody that recognized me to see me. After getting through my shame and realizing that I'm HIV positive, there's nothing I can do about that, but just take care of myself. The stigma hit really hard with me, seeing how when I was on apps and I placed my HIV status up there, that there was no guys wanted to talk to me, no guys wanted to have sex with me. And I was figuring out ways on how I can combat these things, because if I felt like this, I can imagine any other Black or brown man who is HIV positive that's living open with their diagnoses. And so I got myself infused in being a HIV counselor, tester and counselor, outreach worker. I started working in research for vaccine trials. I've really nosedived into the work of the HIV and AIDS field because I felt like I couldn't complain about what was happening around me if I wasn't trying to be part of the solution. And how I found some of my solutions was to be part of social marketing campaign. I've started my brand. I call myself Jahlove the brand. And I started that in 2012. I said, I'm going to be very open and honest and focus on branding and bringing HIV to the forefront and being my full presence. And since then, it's just been something amazing for me to do, to have been part of so many social marketing campaigns that I put my face out there talking about my HIV status, that which led so many people to reach out to me throughout the world via social media or in person when they see my ad on a bus or the kiosk, or just seeing that there's an HIV positive person out there that's really open about their diagnoses. It's almost like I'm a unicorn in batch, right? Like no one sees this. And me being so open and honest about my HIV status through so many social marketing campaigns, I realized that I was actually combating the ignorance and some of the stigma and the shame that other people was dealing with. Some people just needed some of that, just a brave face, just to say that I could connect with that person. So many people, when they see my image in clinics, they reach out to me immediately via social media and say that I just went in and got tested and I saw your face, and it just helped me ease the process. Stigma and shame goes hand in hand. And trying to figure out where that comes from, I know that some of it comes from when it came to the beginning of this epidemic and how the medical community stigmatized HIV, calling it GRID, that it was only associated with gay men contracting this disease. We still have not moved far from that. People still to this day, when they think about HIV, they just associate it with just gay men, right? Because of our numbers. Then we could look at Black gay men numbers, and we're still seen as the face. And so if we're going to still be seen as the face, I felt like I needed to be one of the face to just combat some of that ignorance and stigma. How I'm working hard with my platform, I think that at this point, the science and the data is not matching our laws. We have too many states that have HIV criminalization laws, and those laws still continue to aid to the shame and the stigma associated with this disease. And what we need to do as community members is now we need to make sure that our laws match today's data, match today's science, because we know that HIV positive people, when on their medication, can maintain an undetectable viral load, can maintain a healthy lifestyle for an individual, right? But people on the ground level do not get to see this, do not get to hear this, and which attributes to someone's shame. When someone is feeling shameful of their HIV status, that leads them not to engage in care, which lead to opportunity infection, which lead to so many issues, fatalities, people still dying of HIV complications still in today's times. We need more individuals such as myself just standing out there being the face of HIV. But now that stigma can be a tangible thing, we need to collect more data on how stigma is basically crippling a lot of guys' lives. and bring that information to our local lawmakers so that we can overturn some of these laws, because they have not been aiding us at all. It's still part of the stigma that's associated with. But I feel like using my platform have helped in combating some of those things, but we still have a long way to go. But I'm happy to say that as I put my face out there every day, I know that I'm helping someone feel less shameful for themselves and feel less stigmatizing. So that's what I wanted to add to this conversation, that we truly need to get these laws overturned. That would definitely help with combating the ignorance and the shame and the stigma that a lot of Black gay men face.
Thank you very much, Jahlove.
Thank you.
So I think this is how we do applause now on Zoom, right? So thank you very much, Jahlove. And as you were talking, I can, if you were anywhere inside my brain, you'd be a whole lot of questions going on inside of it that I wanted to ask. So don't worry, take a deep breath. We can be back at you in a moment. Let me see if I can get this thing moving now again. Ooh, this is becoming a, our next presenter is this Nigerian boy. I don't even know, but I tell you guys what, Kachi is an extraordinary young man, a persistent young man. And I say that because he has been trying for many years to present at our In My Mind conference. And it so looks like now that he's in the United States, we are so looking forward to having him presenting at this year's conference, which we are in the process of building and planning. So community members, I'd like us to welcome Onyedikachi Precious Nwogu. Was born and grew up in Nigeria, and for the draconian anti-LGBT laws there, he fled his home country to the US. When he lived in Nigeria, his experiences included as a state technical officer with responsibility for data collection, monitoring, and evaluation, as a marketing manager and a franchise area manager and a marketing executive for a national bank. He earned his Bachelor's of Science degree in financing and banking and is proficient in several related software. Kachi's community work included engaging rural communities and counseling high school students on HIV prevention. And he assisted with triaging clients presenting for HIV care at Jahlove Serrano General Hospital in Ajegunle, Lagos. Community members, I'd like us to welcome Onyedikachi Precious Nwogu. Kachi.
Good evening, everyone. Thank you so much for welcoming me today. It's been, like you said earlier, it's something that I've always wanted to do, and being here today is like one of those things I believe will always come true. Yeah. So basically, you can't talk about LGBT in Nigeria without talking about HIV. In fact, currently, people want to talk about HIV. The first thing they talk about is they talk about the gay men. So basically, I'm going to be giving a brief history of how HIV came about, the criminal laws, the different perceptions of different groups, the Christians, the tribes, and then I'll move it down to West Africa and what we've done so far over the years and what we hope to achieve in the future, or how best we can move care for HIV in Nigeria and West Africa to get the best results. So in 1985, we had the first case of HIV in Nigeria, and it was from 2 female sex workers from a West African country. And the perception among Nigerians then was like, the American gay disease is already in Nigeria. So over time, HIV has been associated with being gay. So that's why a lot of people want to run away from gay men, because the first thing they think about is when they see a gay man, the first thing they see is HIV. They don't see the person, they don't see what they have or what they have to bring to the table. According to a 2019 data obtained from the National Agency for the Control of AIDS, that's NACA, 23% of gay men in Nigeria are HIV positive. That's compared to 1.9% of the general population. And some of the reason for this has been because of the law, the perception of different perceptions, and also the fear of being persecuted, because basically no gay man wants to come out to access care. Over the years working in the gay community, we discovered that even getting tested is a problem among the LGBTQ community, especially the gay community, because they don't want to be judged, they don't want to be discriminated upon, they don't want to be stigmatized for being gay and then for being HIV positive at the same time. I remember in some of our work in the community, I went to one of the hospitals where I used to do like monitoring and evaluation, and I discovered that there was this lady who worked there who identifies as a Christian, and the message she usually passes out to other gay men who come to the facility for treatment is she begins to tell them, if you can change your ways, if you can stop being gay, you get these kinds of natural healings from God. And that kind of made a lot of people turn away from that facility. And that kind of gave us like a huge gap in reaching our targets and our care. Already there was a law before 2014, but in 2014, the government of Nigeria introduced a tougher law which prescribed 14 years imprisonment for any man caught with another man. And if you have an organization, be it you cater for gay men in any aspect, be it health, be it human rights or any form, you are liable to up to 10 years in prison for having an LGBTQ-based organization or supporting gay men. So let's talk a bit about perceptions of different religious groups about gay men in Nigeria. So among the Christians, most Christians believe that HIV is a punishment for going against God's creation. So when you see Christians talking about gay men, they say, oh, because you're engaged in abomination, because you're doing things the other way, because you're engaged in immoral sex, that is why you have HIV. Then among the Muslims of Nigeria, they believe that HIV is a curse from God for living a sinful life. So when they kind of treat gay men and the North far more differently than other issues among other populations in the North. Then among different groups, like the Igbos believe that being gay is an abomination. So, and same thing applies to the Hausas and the Yorubas. And so every bad thing they try to associate with being gay, and then they'd be like, okay, if like I remember some time ago, I was speaking with someone and he said, can't you see that because these people always go against God, that is why their population is always having HIV. He made a statement, he said, show me one gay man who is not HIV positive. So that was like a strong one. And most recently, a king in one of the northern states was trying to associate HIV, homosexuality with an act of the devil, bringing a conclusion saying that it was a divine judgment from God for going against creation. Then let's just jump in quickly into HIV in West Africa. The attitude of other West African countries basically is the same when you talk about Nigeria. It's not much difference. And there are about 16 countries in West Africa. 9 of these countries have strong gay laws. So it makes it impossible to be gay in any of these countries. And if any gay man is trying to access health care or other forms of care, it's like literally impossible. And of these 16 countries, 2 of them have capital punishment for being gay. One is Mauritania, and one is Northern Nigeria. So over the years in my research about HIV in West Africa and everything, I discovered that in Mauritania, there is nothing called care for HIV. A man can't even come out to a hospital to anyone to say, oh, okay, I'm gay, I need care, and any other thing. And this has affected a lot of things. Like if you check out some of the data from these countries, comparing population data for the general population with gay men in terms of HIV prevalence, you find out that the numbers are like, the gap is so huge. Like in Ghana, the general population, the prevalence rate for general population is about 1.6%, while for gay men is about 17.5%. For Togo is about 1.7% for the general population, and then 22% for gay men. And some of the causes of this is because of the homophobic laws in most West African countries. Currently, there are just about 2 countries that don't have such laws, and that is Cape Verde and Guinea-Bissau. And then negative attitudes towards gay men, stigma and discrimination of people living with HIV. So when you have already, there's a stigma, there's discrimination for people living with HIV, with the attitude about perceptions about gay men, so it's like double of whatever a member of the general population will get. And then lack of access to proper health care, fear of arrest and prosecution, lack of tailored healthcare services, and then lack of accurate data for planning, because most of these countries still don't want to accept the fact that there is gay men live in their countries, like I talked about in the case of Mauritania, where there is currently a media campaign that says kill all gay men, kill all female sex workers. So they don't always admit that they have gay men living in their countries. I remember sometime last year in one of the northern states, Bauchi states, where we had like a meeting talking about how we could bring better care to that state in terms of counterpart funding from the Global Fund on prevention of HIV for key populations. And the governor of the state made a statement that in my state, we don't have gay men. So that's some of the issues that most of these West African countries have. They always try to bring up issues like gay men don't exist here, I've never seen them before, and that goes on and on. So over the years, we've tried to kind of create a safe environment for gay men living in West Africa and Nigeria using LGBT-centered organizations, like community-based organizations. And some of the things we've done or we've tried to do is, like we've tried to use advocacy, like in the case of Nigeria. I know we've tried to lobby the Federal Ministry of Health, even though there is a law in the country, even though the National Agency for Control of AIDS said the law will not prevent anyone from getting care, but the reverse has always been the case. Because like I mentioned earlier, you go to some of the hospitals for treatment, for care, you find out that they try to discriminate against you. They try to, in some cases, like the faith-based organizations, try to make it impossible for a gay man to even access care, even when they claim that everybody could get care. And then we've tried to use the community approach, which deals with working closely with community members to reach other community members. We've tried to use social media because no one will open a hospital and say, okay, this hospital caters for gay men. So what gay men do is we try to use social media, hookup apps like Grindr, like Jacked. So we create like profiles using peer workers where the message is get tested, get PrEP, get condoms, get lubricants. So anyone messaging those profiles is actually looking for any of those kinds of services. And then the one-stop shop approach, this was actually meant for the other members of the key population, but it's something that we as community-based organizations in Nigeria try to adopt, using our office spaces as one-stop shop where someone can walk in, get tested, get preventive messages. If they need referrals, they could be enrolled on drugs. Like I know currently now there's an organization called the Initiative for Equal Rights in Lagos, Population Council. They are currently offering these services. And then the HIV self-testing kit. It is recently that it was rolled out by the government, but then it was just, they said it was in trial phase, but it's something that the CBOs, the community-based CBOs for gay men has kind of adopted, and something that we're currently working with. And then we also have tried to include STI management with HIV care over the years in our working. And then some of our hospitals are supposed to be what we call KP-friendly centers. That's centers for key populations where key populations can walk in and access care. So what we have personally done as community-based organizations caring for gay men is we go to these hospitals, try to identify with people who are more friendly, who are welcoming, and we try to train them properly on how to handle issues that has to do with gay men. And then PrEP enrollment it's been a serious issue with the community because of the fact that most people still don't have an understanding of what PrEP is, and it brings about stigma because most people think, oh, once they see the PrEP cup with you, the next thing they assume is ARV. They don't even want to know what happened. Like one of the cases we had to deal with last year, someone came to visited his friend and then saw the PrEP pack and then snapped it and posted it, shared it to other members of their peers, saying that this guy is HIV positive and he didn't say it, probably has been distributing it. And then we had to come in to kind of kill the situation by making them understand that this guy is actually on PrEP, he's not using ARV. And then the partner notification service is something we have used to reach other members of the community who might be at risk of living with HIV. Then what are the future cares for HIV in Nigeria and in West Africa? One of the things we hope we can achieve at any soonest time is policy change. If there's a policy change, then everyone will be able to live freely and be able to walk into a hospital and access care without fear of stigma, discrimination, or being arrested. And then introduction of community pharmacies. Over the years working with the gay community and working in HIV in particular, I've discovered that sometimes when people visit hospitals, they struggle to get the needed care. On the days of appointments where people have to pick up drugs, the queues are always too much. So proposing community pharmacies, which is something we talked about last year too, when we had like a meeting with other members of the community, whereby we can identify pharmacies and areas of coverage where we can send out drugs and people can easily walk in there and pick up those drugs. And then we talk about the peer-to-peer model. It's something that will help more in testing because getting people tested is really a big problem because, like I said earlier, people are scared of coming out to get tested because they don't want to live with the fear, the stigma. Some people will say like, oh, okay, I would rather just live with it and die than just get tested. So if we can use the peer-to-peer model going forward, then we could achieve more, like where we can use someone that has influence in the community to reach other members of the community. And currently, I was proposing with one organization, if we could also try to engage our social media. And then the community workers outreach model, where we engage outreach workers to reach those who are difficult to reach. Like I said earlier, rollout of HIV self-testing kits. Let the focus going forward be more on prevention because we have been working so hard on treatment while the prevention angle of it is really dying. And establishment of more of one-stop shops, training community approach, then try to bring in mental health as much as we can into treatment of HIV and AIDS in Nigeria and West Africa. Thank you very much.
Thank you very much, Kachi. This is actually really quite impressive. I can hear also a number of questions are coming up about HIV in Nigeria and for Black gay men and for the rest of West Africa. Our next presenter is somebody who is a legend in our communities. I'd like community members to introduce you to Ty Martin, who is with Sage Harlem and Sage USA. At Sage Harlem, Ty Martin is the Community Outreach Manager, Program Manager, and Sage Harlem Outreach Worker. As the Sage Center Harlem Community Liaison, he represents the Sage Harlem Center, facilitated by many support groups for elder Black gay men living with HIV for over 20 years. He has heard many stories concerning Black gay men and aging in the Harlem community and facilitated support groups for elder Black gay men dealing with aging and depression. He facilitates the Sage Harlem 50+ Men Support Group that meets weekly on Zoom. So community members, I'd like us to welcome Ty. Ty, welcome. Ty, you're muted.
Yes. Hi, I'm Ty Martin, and I work at Sage, and I happen to be a proud gay man. When I was asked to be a part of this panel, I felt honored because as a community, the elders are sort of overlooked. we are considered not relevant, and that's not on purpose, it's just the culture that we live in. If you're not young or pretty, you know, what's the point? However, if you make it beyond 60, and if you were positive, HIV positive, that's a big deal. I got involved basically dealing with HIV positive people in the late 80s, early 90s, and a lot of them were people that I knew personally. What really got me interested in reaching out and helping people was I had a neighbor who was positive. He was a veteran. He worked for the sanitation department. He was involved in his church and lots of community stuff. And I watched him shamefully die alone. And I remember going to his funeral, which was a Friday night in Harlem. It was a rainy night, and the church was jam-packed with relatives, 3 generations of people, the veterans, all of those people who liked him, and yet and still, because of homophobia in his mind and shame, he did not want anyone to know that he was sick. At that point, I realized, you know, I don't think anyone should ever die under those circumstances. So I became involved with the Harlem Week of Prayer, which goes back maybe 20 years ago. And from there, I started to become more involved with helping, supporting, and learning more about caregiving. At SAGE, I had the opportunity, maybe 12 years ago, to take a closer look at the aging community. And what's great about SAGE is 40 years ago, they made a decision that they were going to advocate and fight for the rights of seniors who happen to be LGBT people. So having the opportunity to work in Harlem allowed me to be able to share our resources, information, because unfortunately with most populations, we are underserved. We're underserved because there are programs available for many of us, and whatever reasons, we're not told about it, and we're not able to step up to the plate. That's one thing. Before I forget, and I just want to quote something that I'd read on the SAGE website. It's basically, there's an article called Emerging Issues on HIV and Aging. And basically what it says is, the purpose of this report is to highlight current knowledge and emerging issues in HIV and aging, on which to develop policy, program, recommendations that will address the needs. And you can always go on our webpage and read the report. It's quite extensive. But what I really want to talk about today is aging, being a gay man who has aged. What we talk about primarily in all of our groups is what happened, you know, like how did this old man get into that young body? And a lot of people like to euphoric recall what it used to be like in the good old days. And yet and still, there's always a sense of sadness when we remember and think about all of the other people who didn't make it this far. So it is a big deal. And a lot of it has to do primarily with the quality of life, that once you become conscious of you're not going to live forever, and that your time is the most important thing that's available. So many of our seniors don't spend a lot of time talking about medications. What they do talk about are the issues that they're dealing with health-wise. And underneath that, there is a sense of not being connected with our own community, be it the people of color or be it the people who are not over 60. That doesn't mean that because you're not prime target, does not mean that you're not interested. And it's assumed that if you're older, that you probably don't have a sex life anyway, so HIV should be the least of your concerns. But those are myths, and that's called ageism. However, what we're able to do at SAGE is provide a safe space where our people who are positive can come and talk about the basic things that are going on in their lives, which in turn creates a healthy, supportive community. With that in mind, what happens is people who are positive in and supportive environment, they're able to do far better. We believe that when you're able to connect with same mind-like people, that there is hope, there's support. Many of our seniors are very concerned about politics, and yet and still they are learning how not to waste their T cells. They're learning that stress does not work for anybody, and it doesn't help any conditions. Also, there's a sense of identification where they can actually come and talk about their feelings and not feel not listened to. We find that when we allow our people who attend our meetings, that there's a sense of family. There's a sense of I do matter. And we're able to help improve the quality of lives for our people. One of the things that many of our positive seniors have come to appreciate is not so much a person's outside, but it's what's within. And many of them realize that when they stop worrying about, well, what's going to happen to me and when will the medications work or not work, and all of this noise in their head, then they're able to be concerned about others. What we did at SAGE at one time was we matched our seniors with younger people, which was a very interesting group, which was basically the New Beginnings group. And each group was able to understand that although we may not look alike, many of us are very much the same from within. Once again, I could go on and on because of my passion, but I do want to reiterate the fact that we all need a sense of safety. We all need to be able to accept ourselves as we are. And once again, I want to remind people that community is far greater than any elusive fantasy. Thank you.
Thank you very much, Ty. And this is really welcoming and really important information you guys are talking about this evening. Before we get to our next presenter, Tim M, who will be joining us shortly, I just want to go back to some of the questions that we had. And maybe we can talk about some of the questions. We've got a couple of comments, Ty, that somebody is saying, thank you for the truth, for speaking the truth. At 61, I'm still on the market and safely knocking boots, not thirsty here. Okay. Somebody, Kelvin and Stephen, are saying thank you, Ty, for sharing. But we got a couple of questions, and going all the way back to the beginning, and I think she just left. But Julia asked a question, which I think might have been, interesting. And she asked the question, what, and I suspect she means why, is HIV important to you? Kevin, Kenyon, you want to take a stab at it? Why is HIV, even though you may be negative, but why is this important to you?
Sure. Thanks for the question, Julia, although you've had to step away. Well, it's important to me because, first and foremost, as a Black person, and certainly as a Black gay man, even being HIV negative, HIV is still very much a part of my entire life. In roughly 1983, I am from Cleveland, Ohio, which is where I now live after living in New York for a very long time. But when I was a kid, in the very, literally 2 years or so, from the discovery of HIV in 1981, I had an aunt who got sick very quickly. I don't even think because it was Cleveland, I think if we had been maybe in New York or DC or a bigger city, they might have tried to think about HIV as a potential diagnosis and maybe, test her at some point, but they never did. They couldn't figure out what was wrong with her, and she died within probably 6 or 9 months. And I forget what the actual, opportunistic infection was or whatever, but I remember years later, my mother and other family members were she's my one of my uncle's ex-wives, but was still very much a part of our family. But nobody thought to look for HIV because she was a Black woman with no history of injection drug use or any of the things that you would consider at the time. So that's first and foremost. And then as I came into my own, coming out in the mid 90s, when I was in my late teens, early 20s. My whole sexual life is shaped by HIV. And I would say probably in the early 2000s, when I was in my mid-late 20s, I started to just have an inordinate amount of friends of mine either seroconvert or begin to disclose to me they were HIV positive. And as somebody who, was already at that point involved in various kinds of social justice work, I came out of initially kind of doing work around prisons and police brutality and criminalization, and then moving into doing that specific work as it pertained to queer youth of color in New York City. I was on the founding board of Fierce when Fierce was getting off the ground in 2000, 2001. To me, HIV made sense to then also kind of to pay attention to as a social justice issue. So it's important to me for all those reasons. I, have family members, friends, lovers, partners who were living with HIV. And so despite being quote unquote HIV negative, when you're a Black gay man at 46 years old as I am, and, probably half of my friends are positive, I wouldn't say that I'm living with HIV, but it's not as though I'm living outside of the context of HIV. And so that's why it's important to me.
Thank you very much, Kenyon. And I think sharing your perspective as a HIV negative Black gay man is important, because that is another side of the HIV conversation that we are not hearing. I remember several years ago, somebody said to me, but we don't talk about how there is a guilt complex that many HIV negative people struggle and deal with, because they're like, well, I do everything like everybody else, but I am not positive. And so that places me in a different category, and it makes me feel uncomfortable. So thank you very much for sharing that. Jahlove, would you want to comment about why is HIV important for you? Is Jahlove still here?
I'm here. I'm
okay.
here.
Yes, Jahlove. Do you want to jump in here and quickly offer a comment on why HIV is important for you?
HIV is important to me as a young person contracted HIV. It's been part of my world. I mean, it's been September celebrating 19 years of me living with HIV. And to see so many communities not being educated properly as far as adolescents, older population, prison population, so many populations, and that if I can contribute in aiding in educating these sub-communities that people don't like to reach to or stay on the ground level, I felt like it was a necessary job for me to step up to. And that HIV is no longer a death sentence, but we still need people still standing up, speaking, and being their authentic self and living out loud with this virus. And so it's just important for me to just be the face and spread my share my light and life with everyone.
Thank you, Jahlove. Kachi, do you want to jump in on this? You want to comment on this question? Why is HIV important to you?
Okay, so basically, like I said when I was talking, HIV currently now is seen as an identity, and it's important for me because I think it's a wrong identity, and I want to see that corrected. That's some of the things that I'm going to be doing going forward, especially as it has to do with West Africa, as West Africa is concerned. Yeah, thank you.
Thank you, Kachi. Hi, do you want to talk to us about why is HIV important for you as an older Black gay man, and why do you see it's important in the older Black gay community?
That's a very good question. For me, it's when a person is HIV positive, they tend to lose hope. And I think there's a lot of self-hating. I'm not talking, well, it's almost as bad as racism or homophobia, but I think also a lot of people, positive people, think that because they're positive that they won't be able to do certain things. And it kind of reminds me of a workshop I gave years ago on HIV in life. And everything that people were complaining about, I can't find a boyfriend, I can't do this, that had nothing to do with HIV. It's about who you are. So to try to lump everything into one category, it puts you in a box that's hard. If anybody's in a box, to me, that means that they cannot help others, really, and it's about taking their experiences. I've learned to look at life positive by listening to people who I think are like, wow, you mean you can survive this and you're still cheerful? So it's a negative, and yet and still, when you look at what happened to the LGBT community or the gay community, before HIV, we were pretty much liberated, gay rights, and we were marching down the street and holding hands. Once that hit the circuit, to reach out to people whom we never would even think about. HIV, it's sad also the fact that so many people, the science was able to take hold. And let me tell you some horror stories about in the 80s when a lot of my friends were doing holistic methods. Something as unbelievable as if you drink your urine that is going to cure, it's going to cure you. And no, I'm not going to take this medication because it's a conspiracy, all of that nonsense. Whereas many of our people in our community, they were dying and nobody was talking about it. So how could anybody be denied the right to live a full life? I thank God that stress reduction, medication, eating properly, and coming out of that self-centeredness will enable anybody to want to live a better life. And the bottom line is that when we had to stop dealing with me, and started to look at others. That's when we started to come together. And, you know, moving forward with the future, look, I don't know about anybody on this panel. Oh, before I forget, I want to thank the panel. I've learned so much from everybody. But when you think about it, if we survive the last 4 or 5 years of a certain person, it's got to be better. And it, you know, I see nothing but hope. I don't know if I answered your question, because at this point in my life, I don't do yes or no stuff. It's all mixed in the mix.
Thank you, Ty. We've got a comment here from someone who says, although New York State has certified peer workers, of which I am one, they are currently underutilized. And I think this is a resource that could bridge the gap in additional cities that may embrace this option. So that's the concept of utilizing certified peer workers or peers to help with, I know they use them in emergency rooms for when there are substance use overdosing, but maybe we can use a lot more peer workers for HIV prevention. I think Jahlove may be able to speak a little bit about that. Another question that we had is, and I think this may be for Kenyon, what about these COVID-19 vaccinations on the priority list or lineup for those living with HIV or AIDS? Do you have a comment or anything you want to say on that?
Sure. So to my knowledge, most of the research, well, all the research that I've seen to this point doesn't suggest that people with HIV have any more risk in terms of illness or death from COVID-19 than other folks. You know, so which is a good thing, right? And I know from the beginning, a lot of folks were very concerned about it. In fact, at the top of earlier this year, when I was still the senior editor at the body, we one of the first things we did was put together a fact sheet, kind of a page with Dr. David Mailbranch, if you are familiar, to help explain to people, because we were getting a lot of, you know, questions through social media and other places with people really concerned that, you know, it would be another, you know, infection that could, you know, that having HIV would mean getting sicker or dying faster from. So it's good to know that we know that. Now, in terms of the vaccine candidates, there's been there was pushback from the HIV community because a number of the companies did not include people who were living with HIV in their research. In fact, actively excluded people, you know, who had HIV in some of the clinical trials. So, and there was pushback to include or to later do sub trials. I shouldn't say sub trials, but like small trials with people with HIV to be able to really prove, you know, safety and efficacy in people living with HIV. So far, what I know is that I do know some people who are living with HIV who have gotten either the first course or now the second course, who are people living with HIV because they are essential workers and that they work in, you know, a range of, you know, healthcare settings, or they're teachers, or et cetera. And so I, to this point, none of the people that I just know kind of anecdotally have had any adverse reactions. But at this point, I have not heard any guidance either at the federal level or any of the states that I've paid attention to that are including people living with HIV on a priority list for vaccination for COVID-19. And I think primarily because there doesn't seem to be you know, that people with HIV don't have more risk of illness or death by virtue of their HIV status. So what will probably happen is that people living with HIV will fall wherever they fall on the list in terms of other things. So, you know, if they're, you know, kind of first line or essential workers, if they work in, you know, congregate settings like senior citizens homes or in prisons or jails, or, you know, and then, you know, if you are, you know, senior citizen if you're over, you know, every state is slightly different, right, in terms of where they're starting their age group. You know, but so people with HIV will fall wherever they fall in those categories, like the rest of us, as far as I know, to this point.
Thank you very much, Kenyon. We've got a couple of questions coming in. And I just want to do one more question, and I think this is really crucial. And maybe Kenyon and Jahlove and Ty, you can try tackling this. I'm going to try and pull two questions here together, because I think if we want to talk about HIV in the future, and Kachi, you may be able to come in on this as well. So you guys just jump in, don't hold back. But I want us to be able to discuss the issue of stigma and shame, because stigma and shame is still present, not just in the wider heterosexual community, but it's still present within our own LGBT people of color communities, and particularly in the Black gay community, that we still stigmatize, we still shame. So one person here has asked a question: how do we break down, how do we dismantle stigma? Is stigma based on homophobia, femophobia, transphobia? And somebody else asked another question about it. And they were saying, you know, can we talk about stigma and its cause? Is it being gay versus just being about sex? So what is stigma, and how can we move forward looking at the future for HIV, HIV treatment, HIV acceptance, HIV in our communities and Black gay men? How do we address stigma? What are your thoughts about this?
If I could just jump in very quickly, I remember when we first started having conversations about HIV, before it was HIV, how it was very stereotyped. I think it was the 3 H's you had. You were either homosexual, Haitian, or what was the other H? Oh, someone who you...
Hemophiliac.
Right, Heron, the 3 H's. Yeah, so that in itself set the stage for a dark, unworthy, you were a bad person. Got it. In my generation, the stigma is still very private. What I'm beginning to hear and see are younger people under 60, even under 40, who do not have a problem with, I'm positive, I'm this, I'm my authentic self, all these wonderful things that may not have been incorporated into their culture. I do know that stigma comes from within. If you feel that you are a bad person because of something that you got, you know, which I don't think anybody deliberately goes out and gets HIV, it doesn't mean that you're a bad person. It just simply means that when you talk about stigma and stereotyping, if someone has cancer, as bad as the HIV skin problem, what do you call that? When you have cancer positive, that's so stigmatized.
Yeah.
Bottom line, it's still cancer. That's what you are who you are. Right. Thank you. If you said to your friends or neighbors, I have KS, as opposed to I have cancer, it's the same dynamic, and yet still the association of that KS is known for AIDS, really. So.
I mean, I think in general, people, stigma still exists, I think, for a few reasons. I think some of it is because, homophobia and transphobia still exists, right? So the ways in which that, HIV is still connected to, our identities in such a way that, so which is also why I say, like, I'm not living with HIV, but like, there's still an assumption because I'm a Black gay man and do HIV work that I am HIV positive. I have dealt with this on a number of occasions, either family members who have kind of like asked me multiple times these sort of roundabout questions about why I do the work that I do. Or I've been on dates with men who, Black gay men who, how did you start doing the work that you do, right? And at first, for a while, I just was like, I would try to answer the question. And then by like the third or fourth time that happened some years ago, I was like, oh, they're really trying to ask me if I'm positive. That's actually really the question. And I just started to just say to people point blank, are you trying to ask me if I'm HIV positive? Like, because then let's start that conversation, right? And so I think stigma exists, for those reasons. And the other thing is, in a lot of ways, I also blame just some, kind of structural pieces in our country where, if I think about, the Surgeon General C. Everett Koop, who in the 1980s sent that mailer home to every household, kind of explaining what HIV was. And this was a conservative, C. Everett Koop was a conservative and worked for Ronald Reagan, a conservative, right? And he, sent the mailer home to every household in the US explaining what we knew about HIV then and there. We've had no such kind of federal engagement with the broader American public about what we know about viral suppression and being undetectable and U equals U. They've not done that for PrEP. So in a lot of cases, people are still walking around with what they think HIV meant when Magic Johnson tested positive. I mean, people literally are still stuck in 1991, right? In terms of like their information. They sort of know that we got the cocktail drugs, but like, that's about it. And so I think that, and so I, come across this, a lot of whatever. And so I think that is one of the things just in my own kind of activism and advocacy that in the new administration, am hoping that there's actually some attention paid to not just, quote, for lack of a better word, ghettoizing HIV. So you only talk to HIV, you only talk about HIV to Black people, to, LGBT folks, et cetera, to drug users, et cetera. And actually, instead of updating the information that the larger American public needs to know about HIV from, at 100 years old down to able to talk and read. And so to me, I think that's where the other piece of the stigma lies, some of which, like I said, is there just because of the existing kind of isms and phobias in our society, but some of it is just that our government has actually done so little to update people. And now that I'm back living in Ohio, I hear like the level of which there were just more Black gay men in New York who understood viral suppression or whatever that I'm encountering far less of here, right? And so there's a lot of work to be done.
Yeah.
Thank you very much, Kenyon, and thank you, Ty. Before we go to our next presenter, someone asked a question which I think it's a crucial question to ask, and we don't talk about too much. Yes, I know we're talking about HIV and Black gay men on this forum, but we cannot completely remove ourselves or be divorced or separated from the rest of our communities. And so somebody's asking the question here. I know someone who's older Black lesbian. She's isolated and discussing her HIV positive status with other people within the community because she doesn't know people who have similar identities to her and are HIV positive. She mentioned that she doesn't want to share her status because she fears being judged by other elders within and outside the LGBT and Black communities. I thought I'd share this because maybe some of you might know of spaces that she could go to and have to and be able to experience groups for Black lesbians who are living with HIV. And along with that question is the whole construct of HIV in the heterosexual community, among straight Black men and among straight Black women, and also HIV in older Black gay men or older Black gay women who out of fear and shame and stigma again are retreating in silence. So I just like us to keep that at the back of our minds and to think about that for a minute. I'd like to introduce our next presenter.
Once again, can I just add one thing? Once again, there are services available for so many of us. It's just simply a matter of reaching out, taking that step, making a phone call. I know, for example, Sage, that's our specialty. If you're over 60, we are definitely the place where you can make that connection. Unfortunately, within the Harlem community, we don't have the type of support that we need. And that's because a lot of our people are staying in their homes, complaining about, I can't find nobody, there's nothing to do. I've seen many people step out of their safety net and connect with others. Community is so important.
Thank you, Ty. And with that, I'd like to introduce you guys to another dear friend of mine, Tim M. West. Tim M. West is an educator and multidisciplinary performance artist, author, hip-hop recording artist, poet, activist, and youth advocate. He worked as an educator and activist in K-12 public schools and at the post-secondary level, teaching and serving as department chair in Oakland and Washington, D.C., and teaching at Eugene Lang College of the New School, Humboldt State University, Houston Community College, and Stanford. His work outside of school buildings include advocating for HIV/AIDS awareness and mobilization at both Aid Atlanta and St. Hope Foundation's Fusion Center in Houston, Texas, and supporting high school students through College Summit. Community members, I'd like us to welcome Tim M. Tim M, where are you? I can't see you.
Oh, I'm here. I've been here. It's so many people that you have to kind of toggle around to see everybody on the screen. So I was actually here.
Welcome, Tim M. I'm so glad to have you.
Yeah. So I'm just going to delve into what I do, which is to give life to some of this work around poetry. But as I was actually going through some of what I wanted to read, a continuous theme came up in my work, and that there's a sort of intermingling between how I'm grappling with HIV as someone that's now been positive for 22 years, and this sort of longing and search for love, often unrequited. And I think we also have to figure out that connection, like how do we help people feel connected? And that, I think when Marlon Riggs said Black men loving Black men is a revolutionary act, it wasn't just about romance. It was also about friendship, companionship, brotherhood. And I feel like that is a piece. We can talk about the clinical pieces. Certainly the mental health pieces are connected to people wanting to feel a certain intimacy. And even the risks that people take are connected to the desire to feel a certain intimacy. So I'll read a couple of these and hopefully we have, this one was one I wrote for Essex. It's called Ceremonies, which is one of the titles of his book. On the other side of what I don't know is what I know. My bedroom, a shrine and the feelings poured into it. Evaporated tear droplets, a smile trapped still in some photo, love potion, seashells, a fortune cookie script, and half a frank incense stick. There'd be pics of brothers now dead that I loved, sprinkled in to give volume and color to my memorial. What I know is mourning and having to wake, get up out of the bed, pray to or curse the gods on bended knee. There is medicine to take, and 3 drenched t-shirts hanging over a computer chair after last night's sweats. I know that it is winter. What I know is that when lonely, there's a telephone in my room with ghetto fabulous messages I can play back. There are pics of ex-lovers. There is Marley and Michelle and Malcolm with poster eyes watching over me. There are bookshelves that stand as evidence of years of hard work, diplomas hanging, other silly accolades, chapters I have not yet found a book for. What I know is that my bedroom is a repository for sadness. There are things in boxes to forget about, silver rings, naive and cliche poetry, perversions like this here disclosure will become. On the other side of what I don't know are certain things, longings, missing mama and baby sis in them. There's grammatology and feminism and post-whateverism that cut the umbilical cord. There's lots of paper and lots of pens that don't write no more, but still there, bleeding like me. So much of my blood has leaked. On the other side of what I don't know are wishes. There are master tools I wish to use to make a dream home, a den with a sofa, a bowl of butter popcorn. There is a ceremony in that place in my head, like in my bedroom in the morning. I shall find a heart still beating and shall dream up a heart to match and a dance with him to house music. We'll exchange silver cock rings and have 7-Up cake at the ceremony. I'll ignore some child trying to read my dashiki. The ceremony. I imagine the family is going in because this time it's real. Mama's little boy has claimed another little boy's smile as his own, for keeps. And to add to the collage of other things he knows, there is the kiss. We untying each other's tongues, forcing our jump to the center of the broomstick till it snaps. And I want to read one more. Hopefully I have time. And I wrote this one because I think we have to figure out a way to recontextualize and reimagine these sort of scary tropes of HIV, these negative, depressive tropes. And so this is a piece called Sweatin'. And if anybody's experienced a night sweat, maybe this will resonate for them. Ignoring night sweats when it's not even hot out. When the cold is barely cool, mocks the crying pores and taunt the body that wants to be held, the body so moist that it slips out of any well-meaning arms, rejecting care and throwing off favorite childhood blankets, turning soft light sheets into AIDS quilts. With each acid sweat drop adding to the burden and heaviness of the way that body reminds Black boys that this crisis ain't just psychological, but ignoring that shit and sleeping naked cool on top of sheets, letting the bay breeze be lover. So some brothers, tortured enough by a guilt they don't believe in, rather than regressing and thinking they can love theyself by hating what they was, and admitting that they done loved wrong, decide only to remember that they loved. Not thinking about consequences, not thinking about tomorrow, just remembering looking into deep, dark eyes and caressing mocha brown skin and giggling or moaning at the tingle before the touch, or savoring the look in the eyes before the kiss and wondering what God in heaven would permit such pain to come from such sweetness. So some brothers defer sadness, and we leave it to the body to cope with the fears and pessimism and the mood swings. And we wake up to double doses of unpronounceable and toxic lifesavers, exercise and eat smart and feel good enough to look handsome to catch the cute boy's eye who might gag at the truth of why we looking better these days. Scared to say more than the blush or wink, because it'd be safer to dream him into the sweetness that conjured up the first night sweat, you know, the good kind, before we over-contemplated coughs and blisters and little itches. We push ourselves to remember the beauty of sweat drops that get favorite childhood blankets thrown off onto the floor and make the body so wet that it slips right into well-meaning care. And with each limb-lock nectar dripping, with each over-anxious sip kiss, remember that there is so much good about the way we make love with each other. So much that the next night sweat reminds not of 3 or 4-letter dis-ease acronyms, but of 2 and 5 and 4 and 7-letter nigga beauties, Chris and Tony and Daryl and Derek and Ed and Michael and Dante and Rodney and Frank and Baby and Boo and Lover and my boy and my nigga that come to this here place to sweat with me in this here healing pool that sometime be the only safe place we have that love us, right here under these here wet covers, sweating. Sorry, y'all. I hadn't read that one in a while.
I think we just got to take a moment just to soak it all up. So just quiet. Let's just take a moment to soak all that in, because that language. Thank you, Tim, man.
Hey, y'all made me cry. That wasn't supposed to happen, but
It's beautiful.
I think it's okay to claim our bodies as worthy of love and sex and joy And I think one of the things that HIV has robbed us of is the ability to really celebrate those things, right? To celebrate our love and our magic. And when I think about Essex and Asoto and Melvin and so many of my mentors who've gone before, that's what they taught me when I was a little gay baby activist at GMAT meetings in New York. That's what I remember. That's what I hold on to. So thank you.
Thank you very much, Tim M. And I think the way that how this evening's forum played out, this is the perfect end to it. Yes, reclaiming our bodies because we've been demonized just simply for who we are. As Kachi, as Ty, as Jahlove and Kenyon were saying, that, you know, how the shame and the stigma about HIV makes us feel. So thank you very much for that. Well, we did the Q&A already, so we could just move past that. So I just want to thank you guys very much. To our panelists, Kenyon, Jahlove, Ty, Onyedikachi, Tim M. We want to thank our community partners, AmidaCare, Brooklyn Community Pride Center, Callen, Lorde, Caribbean Equality Project, DBGM, of course, SAGE, and just to acknowledge that this event was made possible by a micro grant from New York City Department of Health HIV prevention. Next month on February 11th, we're doing a forum on drumming, on healing, drumming as healing, reaching to our ancestors. And so we are going to spend some time in an hour-and-a-half session in February 11th, looking at how drumming is important for our healing and for our mental health. We'll be featuring Italian Arawak people from the Caribbean. We'll be teaching African drumming and some Indian drumming from India. And then after that, then they will discuss how drumming is important in cultures and how this is something that we may want to reconnect or get back to, even if it means listening to a pre-recorded or a DVD or a YouTube video of somebody drumming, but the sound of drumming and what it does to our bodies. So once again, thank you guys very much. And thank you to all those who tuned in. If your questions weren't answered, I don't think there are very many questions that weren't answered. And I think I really like how this evening played out. Because I wasn't sure that you were on, Tim M. So I decided to go ahead with the questions. And that kind of took up and helped to kind of like fleshed out a lot of what Kachi and Kenyon and Jahlove and Ty were talking about. And then you coming in now with your poetry and just closing us out and bringing us all in and helping us celebrate our bodies and ourselves. So thank you very much for that, Tim M. Kenyon, good seeing you. Good seeing you too, Tim M. Ty, good seeing you, Kachi. We'll be in touch and talk some more. Jahlove, I look forward to talking to you some more, and thank you to Mohammed for recommending you to be part of this. So once again, thank you guys very much. And hopefully I'll see you guys on February 11th again. All right? Thank you.
Thank you so much.
Yes, thank you.
Thank you.
Thanks.